Good morning, Mr. Chairman, ladies and gentlemen. It's a pleasure for me to participate in this interesting meeting, interesting session. After the excellent talk of Catrinotto, I'm going to focus in the role of echocardiography in the advantages and limitations in clinical practice. Nothing to declare. In clinical practice, echocardiography is the best or the most useful technique in the diagnosis of aortic of a bicuspid valve. The sensitivity and specificity is over 90–95%, but it depends on the quality of the image, the presence of calcification, or the experience of the explorer. Not all cases are easy. As Dr. Otto said, we know the classification of the bicuspid aortic valve, the type 1, that is the most frequent, around 70–80%, the type 2, and the vertical one, and the more rare, the type 3. And the pure bicuspid valve implies around about 30% of cases without RAFE. The 70% we can identify the RAFE. So this is a case that a type 1 bicuspid aortic valve. We can see here the RAFE located at 1 o'clock, and we can see the fusion of the left and right sigmoids. And in this other one, we can see the RAFE here is a type 3, and we have the fusion of the left and non-coronary sigmoids. If we consider the natural history of this disease, really we identify that the most significant problems in these patients is the degeneration and the dysfunction of the aortic valve. In the Michelena study, in 25% or 24% of cases presented or required aortic valve surgery in 20 years of follow-up. And it was related with the degeneration of the valve. Really, in the paper, the degeneration is classified or was classified as semi-quantitative, mild, moderate, or severe. And it's not easy to say what is a mild, what is moderate, or what is severe aortic valve degeneration, but it seems clear that the degeneration of the valve plays a significant role in the evolution and the requirement of the aortic valve surgery in bicuspid aortic valve. So the critical point, and we use the echocardiography in this way, is to identify the degeneration, fibrosis, and calcification of the valve. That is curious because that is absolutely heterogeneous. There are some cases without any degeneration, others, young people without cardiovascular risk factors that presented localized calcification, and other cases that evolve with severe fibrosis and calcification. These cases presented when they arrive to 60 aortic stenosis and require surgery. But the reason why in some cases evolve quickly or not to degeneration is not clear at all. In aortic regurgitation is caused for different reasons. Some of cases are secondary to fibrosis, but the other are for the prolapse of the larger sigmoid, as this one, non-coronary sigmoid that is large, and presented a prolapse that usually generated an eccentric jet that is not easy to quantify, because when we use the vena contracta, we can measure this width when we have the other that we cannot see by echocardiography. So we need to use probably several methods to quantify correctly the aortic regurgitation in bicuspid aortic valve. And the vena contracta, but also PISA, also the descending aorta flow, and try to measure correctly using different approaches. I would like to show this case that is a 24-year-old man that I control in my office. It was a bicuspid valve, a type 1 bicuspid valve that presented at 24 years old this fibrosis in the valve, a severe aortic regurgitation. After 10 years or 9 years, this severe aortic regurgitation evolved to a severe aortic stenosis, and the valve changed significantly and presented some calcifications and severe fibrosis. So we can see that the natural history of this valve changed from severe aortic regurgitation to severe aortic stenosis. And curiously, the aortic regurgitation decreased significantly in these 9 years. Regarding the relationship between the aortic valve and the ascending aorta, as was said by Dr. Otto, we have 3 main phenotypes in ascending aorta: the normal phenotype, the phenotype with ascending aorta dilatation, the tubular part, and normal aortic root, and the phenotype with aortic root and ascending aorta dilatation. The relationship between the types, the valvular types, morphological types of bicuspid valve and the ascending aorta morphotypes is not absolutely direct. There are a percentage of cases, as it was said, that presented this type of ascending aorta dilatation, the tubular part, that are a type 2 bicuspid valve, but it's only a frequency changes around 60–40%, but never is 100% evolved with one type of ascending aorta dilatation. So there are other factors, mainly aortic stenosis, aortic regurgitation, age, that can play a role, and is not only a direct relationship between the valvular morphology and ascending aorta dilatation. A critical point in the follow-up of patients with aortic valve disease is to assess and to measure the ascending aorta dilatation, because it's a part of the indication for surgery. In these cases, when the aortic root is dilated, we can measure easily the diameter by echocardiography, but in these cases, it's very speculative because we don't know if the aorta dilated more in the upper part of this tubular segment. So in these cases, I think it's better to perform a CT or an MRI and to be sure that we have the maximum diameter in the ascending aorta. This is a case that I suppose you identify immediately, that a patient with a bicuspid valve and Marfan syndrome. The morphotype is typical of the Marfan syndrome more than bicuspid valve in these cases. And I would like to show you also another case that is a patient of 34-year-old mountain climber that presented this bicuspid valve, a vertical type, with this localized calcification in this part of this commissure, anterior commissure, presented a mild aortic regurgitation, and the ascending aorta was 49 millimeters. That we perform an MR, and we show that the diameter by MR was 53 millimeters, 4 millimeters more. And I would like to know what will be the medical strategy in this case, because this man wants to maintain the sport alive, and this ascending aorta that is 33 millimeters, and I don't know if my surgeon can repair this valve or not, or only indicate a replacement of the ascending aorta and the aortic root. I would like to have the opinion of the surgeon. And on this patient, I will visit the patient in 3 months, so it's a difficult decision because I understand that the ascending aorta is better to replace the ascending aorta, but they have a mild aortic regurgitation with a localized calcification in this commissure. It's not exceptional to obtain a difference of diameters between echocardiography and MR on CT. In the previous case was 4 millimeters. In this case was 8 millimeters, and that is important. Why? Because around 20% of patients with bicuspid valve have an asymmetric aortic root, and we measure by echo the right coronary, non-coronary diameter, that is this one, 44 millimeters. But we don't have this diameter that was 52 millimeters. So in my opinion, it's important in bicuspid valve around 45 millimeters to perform a CT or MRI and to rule out the presence of asymmetry. Because if not, we identify only the smaller diameter in some cases. And this is another case that I would like to show you. That is the typical situation in the echo lab that the fellows ask you, this is a bicuspid, a tricuspid valve. It seems clearly a tricuspid valve. But the ascending aorta was 44 millimeters. So we perform a CT, and we obtain a tricuspid valve, but with this raphe. It's a small raphe. The point was that this person was a colleague of our service, and his brother died for a type A aortic dissection with bicuspid aortic valve. So I don't know if these mini raphe are part of the disease. Is on a spectrum. I'm not sure about that because they say that to take into account that the raphe should be 50% of the length of the sigmoid. But it's curious that this person presented this mini raphe, and his brother died for a bicuspid valve with a type A dissection. You can see the ascending aorta was enlarged, 44 millimeters only, but the morphology is abnormal completely. So I don't know if that is a case of this publication that they say that the patients first-degree family of the bicuspid valve presented also aortic dilatation with tricuspid valve, but I'm not sure about that because other studies posteriorly didn't show this enlargement of the family members. So I don't know if there are part of the family members that presented mini raphes that also are bicuspid frustre bicuspid valve, and that generated also some problems in the flow in the ascending aorta that are the cause of this type of dilatation. So I think partially this patient had a frustre bicuspid valve. And finally, this is another case that also I think is interesting. That is a patient, a family, a father of 56, that presented a type 1 bicuspid valve with an ascending aorta of 42 or 41 millimeters. And the son presented a type 2 bicuspid valve, so exists a disparity in the type of bicuspid valve in the father and the son. And the son had a 46 millimeters of enlargement. So you can see a disparity in the morphotype and a disparity in the ascending aorta enlargement in the same family. This is the algorithm that we use in our hospital. We perform a transthoracic echocardiography. When the aorta is less than 45 millimeters, we consider now the possibility to perform a CT or an MRI in order to have the basal study and to rule out the presence of asymmetry in the aortic root. We control the patients biannually and control the risk factors. When the aorta is over 45 millimeters, we always perform a CT or an MRI. When the diameter is between 45 and 49, we perform a transthoracic echo annually if the measurement agree with the CT and MRI. If the measurement is between 50 and 54, we perform every 6 months the transthoracic echo. But in the cases with a history of coarctation or systemic hypertension, or the dissection or rupture in the family, or the growth rate more than 2 millimeters per year, on severe aortic stenosis, we indicate surgery, the same as when the diameter is over 55 millimeters. So it is important to use the multimodality in bicuspid aortic valve, mainly when we have only a dilatation significantly in the tubular part of the ascending aorta, because in these cases we need to have an MR or CT for control. My conclusions are that transthoracic echocardiography is the primary imaging tool for the initial diagnosis and serial follow-up of patients with bicuspid aortic valve. At the time of initial diagnosis of aortopathy, aorta dilatation, CT or MRI is generally recommended to confirm that the aorta size is not underestimated by transthoracic echo due to the eccentric dilatation of the aortic sinus. Transthoracic echo can be used for serial imaging follow-up of the ascending aorta when correlation between the dimensions measured by transthoracic echo and CT or MRI has been confirmed. Other imaging techniques such as CT, and particularly MRI, biomarkers, and genetic may help to define the rapid progression in valve degeneration, hemodynamic dysfunction, and aortic dilatation. Thank you for your attention.